It is my pleasure to introduce Dr. Sacha McBain, an assistant professor in our very own Center for Trauma Prevention, Recovery, and Innovation. Dr. McBain received her bachelor's degree in psychology from the University of Utah in Salt Lake City, then received her master's degree in Ph.D. in clinical psychology at Palo Alto University in, you guessed it, Palo Alto, California. She joined us in Arkansas to complete her clinical psychology internship here at UAMS, then completed a postdoctoral fellowship at the Central Arkansas VA MIREC before joining our department as faculty. Dr. McBain has only been in our department for 2 years, but wow, has she made good use of that time. Since joining our department, yeah, we have to be immodest here. Since joining our department, she has served as PI for 2 intramurally funded projects, both seeking to improve the fidelity and accessibility of PTSD screening. She has also published 11 peer-reviewed manuscripts as faculty. Dr. McBain joined UAMS to serve as Associate Director for the Center of Trauma Prevention, Recovery, and Innovation. In this role, she leads implementation of screening and brief intervention efforts on UAMS's trauma surgery service, which is one of the few trauma psychology consult services in the United States designed to address the mental health needs of traumatically injured patients. She also currently serves as an expert panelist as part of the American College of Surgeons Post-Injury Mental Health Best Practices Guidelines Workgroup, and is a clinical expert in the field of medical traumatic stress. So I will go ahead and hand it over to Dr. McBain. Welcome.
Thank you. Thank you all for being here and for the nice warm welcome. Today I'm going to be talking about treating hospitalized trauma survivors for PTSD and talking about implementation of the trauma psychology consult service. There we go. You've heard a little bit about me. In terms of my kind of clinical training, most of my work has been in integrated care settings. So along with getting my PTSD treatment training and expertise in prolonged exposure and cognitive processing therapy, I was really interested in integrating that into hospital-based systems. And so a lot of my training, I was kind of patching together getting PTSD training, but also what it means to be a health psychologist and working in an integrated care setting and kind of bringing those things together to address medical traumatic stress. So that's been working in rehab settings, emergency departments, and then of course now working within our Department of Surgery on F4, which is our progressive med-surg unit, and also our surgical ICU H4. So today I wanted to, not many people here are not going to be maybe implementing their own kind of consult service. So I wanted to start with talking about best practices regarding screening, prevention, and treatment for PTSD and things that you may be able to apply within your roles or as you're developing new programs. I'd then like to talk about what the core components of a trauma psychology consult program are, and then thinking about, I hope that you'll leave here promoting the role of integrated care and thinking about post-injury mental health programs and how we prevent and treat PTSD in these integrated care settings. So what we know is that each year about 30 million people are injured in the United States, and of those, about 2.6 million require hospitalization for their treatment. Of those that are hospitalized, 1 in 3 patients will end up meeting criteria for PTSD and or depression within that first year. And then 1 in 5 will report some poor mental health outcome related to their injury. So this is a huge population of people who are experiencing PTSD. When we think about PTSD, we often are thinking about, the red flags of the symptoms that we all know about. But when we're thinking about PTSD in the context of injury, it's important that we think about the other potential implications of that. What we know is that it used to be that hospitals were primarily measuring mortality-based outcomes. Are people surviving injuries? We've gotten really good at keeping people alive, but that has come with what is happening to people when they leave the hospital. And so there's been a lot of focus and system change on how do we address health-related quality of life outcomes. And what we know is that psychological distress following an injury is one of the strongest determinants of disability in that 12 months post-injury, which is a major outcome that hospitals are looking at. We also know that PTSD increases the likelihood of chronic pain, which then we all know cascades into lots of other difficulties regarding mental health and substance use, and also other negative post-injury health-related quality of life outcomes. PTSD is also related to readmissions for substance use-related injuries. And so if we're thinking about trauma recidivism and injury prevention, addressing PTSD in this early post-injury phase might actually change the course of somebody's risk for later injury. The American College of Surgeons recognizes that this is a problem, and in 2018 released a recommendation that, or encouraged level 1 trauma centers to be implementing a screening and referral protocol for the care of trauma patients. There's been a bigger emphasis on thinking about how we address the psychosocial needs of trauma patients more broadly, including things like hospital-based violence intervention programs that include a mental health component, and also lots more research to understand PTSD and other related outcomes in the context of injury. So where are we now? Back in 2014, there was a study done that showed that approximately 7% of level 1 trauma centers screen for PTSD. I don't think that that percentage has changed very much in the last few years. And that was compared to 93% of centers at that time were screening for alcohol use. And I think that percentage is probably a little bit higher now, given ongoing recommendations and associations with trauma verification. But I think that this shows it's a good comparison when we think about what is getting in the way of PTSD screening when we're doing these other types of, more psychosocial screenings per se. I think that part of it is that alcohol use is more kind of solidly within kind of the scope of medical training, understanding how to intervene, what to do, and things like SBIRT are pretty well established. We kind of know the steps to take. Whereas when it comes to screening for PTSD, I think that there's a pretty significant lack of knowledge or expertise integrated into these systems to know how to screen, to know what to look for, and then to know how to intervene. Even for places that maybe do know how to screen and maybe even how to refer, there's a lack of resources. Who's going to do the screening? Where are we going to send people? And so I think that one of the things that I hear over and over again from people working in centers who have some ambivalence about PTSD screening is, I don't want to ask about something that I can't do anything for, or I don't know how to get people connected to. And so that's where we kind of need more resources and thinking about increased organizational support and advocacy to get this expertise into these centers to help build these programs. And then it's actually like, what do we actually do to address the problem? And I think that part of why implementation has been slow with this is that even within the field of early intervention, prevention for PTSD, we still have lots of questions that we're trying to answer within our field. And so how do we expect hospital systems to implement something that we don't really have a clear sense of yet? So some of the core questions that come up in the field of early intervention are things like, who needs assistance after a trauma? When is the quote unquote right time to help somebody who's been trauma exposed? What do we do to actually help them? And then thinking about the scale, and then how do we address this on, from a public health approach? So I'm going to take some time to kind of talk through how we answer some of these questions, what we know, and maybe where some of the gaps are. When we think about who needs assistance after a trauma, what we know now is that most people will be exposed to some potentially traumatic event in their lifetime. And many people will have some early reactions, but will go on to then recover naturally. For those who don't, they may develop a trauma-related disorder, including acute stress, PTSD, or maybe another mental health disorder. So when we think about PTSD specifically, we kind of conceptualize it as a disorder of recovery. And so if there's things that we can do to help promote recovery, that's where we kind of want to be moving the focus of our intervention. We know that when we think about who needs assistance after trauma and who's more likely to go on to have a reaction than to go on to have a disorder versus those who don't, is really thinking about risk factors and thinking about them in the context of pre-trauma risk factors, peri-trauma, what's happening during the event itself, and then what is happening in that post-trauma phase. And so when we're thinking about how do we tailor assistance, we have to really consider those biopsychosocial risk factors, the nature of the event itself, and then what is happening after the trauma. Some of the common risk factors that we see related to post-injury in this pre-trauma phase, kind of thinking about the soil that the seed is in, so to speak. I'm going to make a lot of tree analogies through this talk, just so you know. Thinking about that soil, like what's happening in this pre-existing environment that contributes to that vulnerability, that risk to develop distress and PTSD. Some of the things that we see in the literature: minority status, limited education, low SES, pre-existing trauma or adverse childhood experiences, prior mental health concerns, and then kind of pre-existing life stress. I think it's important to note that when we're talking about minority status, we're not talking about, and this is thinking about race, ethnicity, gender identity, sexual identity. We're not thinking about this as something inherent within, that person given that identity, but really thinking about how they're engaging in the world and the unique types of stressors that they're facing given their intersecting identities that puts them at greater risk when experiencing additional traumatic events. When we think about the peri-trauma risk factors, the things that we know about the trauma itself that contributes to risk, is that perceived life threat. Even though that kind of subjective component of the PTSD diagnosis has been removed from the DSM-5, we still know that if somebody really perceives that they were going to die, or that they perceive this is a really serious event, that increases their risk for later PTSD and their meaning making of the event. The trauma type, so intentionality is a really significant risk factor and something that we definitely screen for on the consult service. And then seeing another person hurt or a dead body is another peri-trauma risk factor. In the post-trauma risk phase, we're really thinking about acute distress. And that makes sense, right? If we think about, we're looking at risk for PTSD, if somebody's having enough distress, enough reactions that they might meet criteria for acute stress disorder, if we just give them that month, then they're more likely to meet criteria for then PTSD. And also, like, high levels of distress kind of block some of the natural recovery, which we'll be talking about. Another thing is lack of social support, but also not just lack of social support, but the presence of something that we call social constraints. And the social constraints are behaviors that, intentional or unintentional, that are minimizing adaptive emotional processing. Well, what were you doing? Why did you do that? Oh, just get over it. It's not that big of a deal. All of those kind of social norms around how we talk about somebody's trauma experience that infiltrates how they're making sense of it, and also can kind of limit that adaptive talking about the thing that happened that we know is good. And then life stress. This can be that continuation of pre-existing life stress, but also new obstacles that are brought on by the trauma that are making it difficult to focus on recovery. I think that one thing that's unique for this population is thinking about how that life stress is compounded when somebody is interacting with the context of healthcare. Many of the interventions that the patients that I see require, while life-saving, are incredibly traumatic in and of themselves, let alone that what brought them to the hospital to begin with. And so when we think about what medical trauma is, or medical traumatic stress, is it's these reactions to pain, to injury, to that serious illness, medical procedures, treatment experiences that are happening in that technically post-trauma phase, but it's really a continuation of the trauma and a layering and compounding of that original trauma. So if we think about two people who are in the same car accident, for instance, somebody who walks away from that car accident is still at increased risk for PTSD, but it's a contained event. It's something that they can, while not adaptive, they can avoid if they want to. They don't have to get back into a car, for instance. Whereas somebody who's in that same car accident, but is life-flighted, intubated, and ends up losing a limb, has chronic pain, you can see how there's these compounding stressors that are impacting somebody's ability to recover. And also that the trauma reminders have now become within the body. And I think that that's a reason why things like uncontrolled postoperative pain are an increased risk factor for later PTSD, because if we think about those learned cues and what's contributing to the development of PTSD, every time somebody has a pang of pain or uncontrolled pain, the brain is saying, I'm in pain. And why am I in pain? Because this horrible thing happened to me, and then kind of contributes to this re-experiencing and re-triggering of the original event. We also know that perceived and actual mistreatment by staff within a care environment is also another significant risk factor for this population. And in qualitative interviews that I've done and in my clinical work, it's actually is one of the most salient that patients talk about. And this feeling of being marginalized or disempowered within their context of their care, and that loss of autonomy is really, really difficult for people. And so that's a unique component of the experience of those who are experiencing PTSD post-injury, and those who are hospitalized specifically. So when we think about when is the right time to help, my key point here is that people are on different recovery trajectories. And if we're kind of just to look here, we might not necessarily know where somebody's going to go. We have the chronic trajectory, the people who, like I mentioned in those post-trauma risk factors that are high distress early on, and they're staying high without any intervention. We also have those who are on a recovery trajectory. So there's people who may have pretty moderate or significant observable reactions to the event, but over time, without any direct intervention, are going to naturally recover. I often just describe this to my patients almost as like that big roller coaster ride where you're kind of coming up, and we kind of expect that those reactions will come high and then gently come down over time. For some people, that stays stuck. And that's that delayed, that might be that chronic trajectory. But then there's others that there's more of this delayed trajectory where they're kind of doing okay. They might have some mild, moderate symptoms in the hospital or in those early days and weeks. But then over time, just finding that it's not only not changing, but it's actually increasing over time. And then finally, there's that resilience trajectory. These are people who maybe have some reactions early on, but then are kind of going on to not have any real significant reactions. So this is a hard part of early intervention because we don't really have an exact science to know who's going to end up on what trajectory. And so our goal is really to get somebody on a recovery trajectory, and for those who might be at increased risk for a chronic or even a delayed trajectory. So it's important that we aren't over pathologizing early reactions. And that's was part of one of the fatal mistakes with things like critical incident stress debriefing, which was determined to actually be harmful because there was this over pathologizing of those early reactions. Well, if you're having nightmares, if you're thinking a lot about what happened, that's really not a good sign. That's a bad thing. And so that increases kind of this anxiety and anticipatory anxiety around having these symptoms that just contributes to kind of continued distress. So we need to make sure that we're letting people know it's normal to have some of these early reactions. And if you notice that they're not changing over time, that's when we need to start thinking about some intervention. It's also important on the flip side of if somebody's not having a reaction early on, that doesn't mean that they're necessarily out of, they're in the safe zone when it comes to developing PTSD with that kind of more delayed trajectory. So we're going to approach those patients a little bit differently because we don't know if they're on resilience or delayed, but we want to kind of do a watch and wait and routine monitoring around those who might end up developing PTSD later down the road. And that's what's important to think about, a continuum of care. So when we think about what blocks natural recovery, for any of you who are providing direct clinical services, these are pretty face valid things that we would think of getting in the way. PTSD at its core, in some people's conceptualization, is avoidance is key, or a core of what sustains PTSD. And so if somebody's engaging in extreme avoidance very early on, that might be a sign that natural recovery is going to be blocked. as that also goes along with lack of processing, kind of pushing it away, not dealing with it. You may feel okay in the beginning, but ultimately there isn't that kind of natural recovery process occurring. Excessive anxiety, fear of that anticipatory anxiety around having reactions can also block natural recovery. Using substances, withdrawal, that low or limited quality of social support, those continued losses or obstacles are all things that are kind of getting in the way of that natural recovery. It's also important that we don't think about this just on the individual level. There's also things happening outside the patient, in their context, in their environments, that are getting in the way of natural recovery. Somebody who's chronically exposed to toxic stress or other stressors or constant re-traumatization is going to have a difficult time with natural recovery when faced with all of these other types of stressors. Mental health stigma, how somebody's understanding themselves, how their community is responding to them having reactions, all is influencing somebody's understanding of themselves and their ability to kind of engage in processes that would help natural recovery. So when we think about what should we be doing to help, if we know that these are the things that are blocking natural recovery, then of course we want to flip that and do the things that are going to help facilitate recovery. And so the first and foremost is increasing therapeutic exposure and facilitating that emotional process. So when people are experiencing PTSD, their world tends to get really small. There's a lot of avoidance. There's a lot of kind of learned cues about and overemphasizing the danger in the world. That's hard to challenge when somebody's not actually back out in the world and seeing that things aren't dangerous. And so part of what we're doing when we're thinking about natural recovery is, how do we approach stressors, see that it's safe, see that you're capable of dealing with it, but not kind of leaning too hard into avoidance. So that's a really important part of that natural recovery. And at the hospital level, we're really doing more talking and educating around that rather than doing that kind of direct exposure. At least in my program. There are programs like the program at Emory where they are actually doing brief, prolonged exposure in the hospital, but we have not gotten there yet. We also want to make sure that we're enhancing coping, that we're helping people to be able to tolerate the difficult emotions that are coming up and helping to reduce those losses and obstacles that are coming up as a result of the trauma. On a bigger level, thinking organizationally or as communities, I think that there, especially in the last couple of years, there's been a lot more conversation around the role of mental health professionals and psychologists, et cetera, in thinking about these larger barriers and how do we support community recovery. So these may be aspirational for many of us in our kind of current role, but thinking about, at minimum, how do we help people access the resources that they need? How do we get them access to the social services? How do we think about physical safety? How do we, help people problem solve around some of these bigger issues and environmental factors that are getting in the way? And these are some of the ways that we can look at that. So the International Society for Traumatic Stress Studies in 2020 developed these PTSD prevention and treatment guidelines, or they published the book in relation to the guidelines that were actually published in 2018 to give more guidance to clinicians of what's working, what should we use in order to help people at the individual level. So I'm going to go through some of these guidelines. They're based on the Institute of Medicine's kind of prevention framework and with the addition of early treatment. So when we think about on what scale should we help, everybody wants to do the universal. We want to be able to just give a broad-based intervention, just cover our bases. Anybody who was exposed to the event, just give them something and hope that that prevents PTSD or prevents any symptoms from developing. Selective or indicated interventions are those that target that higher initial symptoms in order to prevent disorder. So these are people who are having some reactions or are at minimum at increased risk. And then we're trying to help prevent PTSD. And then early treatment is targeting those who have those or experiencing symptoms or have developed a trauma-related disorder, but it's in its early phases. So if we can think about universal prevention as trying to do the whole forest, and what we know is that when we try to target interventions to anyone, regardless of their symptoms, it's not effective. And part of the reason, I think, is because of those trajectories of partly, you know, when you try to study it, some of these results wash out because there's going to be the people who are going to get better no matter what you did. But then there's also, you know, thinking about things like debriefing, where there's that over pathologizing of the reactions that can sometimes get in the way. And so it's not always best to kind of target to everyone, because it can be at minimum ineffective and actually has been found to be harmful in some cases. Even though we can't do maybe a direct intervention, we can still do things as a system and as individual providers to help facilitate natural recovery for all patients. And really that's just, you know, we can create this foundation of good care that anyone will benefit from, and those at greatest risk will also benefit from and need. One of those approaches is psychological first aid. We've been hearing a lot about PFA and stress first aid and all of the iterations of this in the context of COVID, for all of these same reasons, where lots of people potentially exposed to traumatic events, but what do we actually do? And so psychological first aid is not a formal therapy, but it is an approach to offering support. And the psychological, you know, pure mental health component is actually the smallest part of it, where there is some kind of information on coping and what to expect. But really, it's getting at those other pragmatic or practical barriers to recovery, making sure people have access to resources, that their basic needs are met. And this is an approach that's been, we can't prove that its efficacy in terms of preventing PTSD, but we do know that it's not harmful, and in many cases can be helpful just for coping and other things for patients and people. And so it's been endorsed by lots of different organizations as an approach to provide support in the early days and weeks following a trauma. We also know that a trauma-informed approach is really important. So if we think about hearing from people who have been traumatized in the context of their medical care or in the context of an injury, saying that it's the environment that they're in, it's their interactions with people in the environment that are contributing to their distress, we can modify that by implementing and adopting trauma-informed approaches in these settings. We can potentially mitigate some of the impact of the frightening medical events by using some of these trauma-informed principles, changing the things that we know are risk factors, and really helping patients and their families cope with these emotional reactions. And also, we know that a trauma-informed approach doesn't help just our patients, but it also helps us as providers and all of the team members working within our system. When we think about selective and indicated interventions, this is rather than focusing on the whole forest, we're focusing on the part of the forest where maybe a fire is approaching, or there's been a fire and there's some damage. We're putting our resources to where there is current distress. So we're kind of narrowing in. And so there's a lot of emerging evidence to support the effectiveness of providing interventions to those who are experiencing distress but not yet meeting criteria for a disorder. And so there's in the guidelines, there's some very specific interventions that were recommended, but I think that the key components of them are they each focus on psychoeducation, helping people to know what to expect, understanding what to look out for if they're having, in continued signs of distress, building skills, how to cope when those things come up, and then some emotional processing, or at least promotion of later emotional processing. And these are types of interventions that can be, or focusing on these aspects can be done during hospitalization, during follow-up clinic visits, or in specialty mental health care, as we're all familiar with. When we think about early treatment, this is where we're really getting into the individual and what their unique needs are and how we need to best support them. And so these are designed for those who are experiencing clinically significant PTSD symptoms, or those who have developed PTSD, but we're still within that 3-month window. So it's still a really early diagnosis. And for early treatment, all of our standard interventions apply here. Cognitive behavioral therapy with a trauma focus, things like prolonged exposure, cognitive therapy, cognitive processing therapy would fit there, and then brief EMDR therapy. Programmatically, when we're thinking about early treatment, this is likely going to be provided more so on the outpatient basis in that outpatient specialty clinic or in an integrated care setting. So the question then is why do this in an inpatient consult service model? You know, these recommendations can be applied in lots of different settings. For me, I think that why this was important to me is that I think oftentimes when we're thinking about treating PTSD, and we know that one of the core components of PTSD is avoidance, and yet we wait for people to come to us to talk about the worst thing that's ever happened in their life. And so to me, that seems like a missed opportunity in capturing people earlier in the process and getting them the support they need to get them on that natural recovery, rather than somebody showing up to treatment 5, 10, 20 years later after experiencing a traumatic event, if at all. And so I think embedding a mental health professional or psychologist, in my case, into the setting where a trauma is happening increases opportunities for that prevention and early treatment that we don't get for a lot of different types of trauma. We know where these people are going to be. Why not meet them there and provide the treatment? We also know that when thinking about developing this program, there was the question of like, do we start with outpatient or do we start with inpatient? And I think for me, why starting with inpatient was important is because I think that we know that the trauma population has a lot of difficulty with follow-up, even getting back for routine physical follow-up. And there's a lot of reasons for that. There's significant health disparities that are occurring within the trauma population. For some people, they're losing their only mode of transportation. Their injuries are limiting them from being able to travel. That's changed some with telehealth, but we also know that there's a lot of other barriers and psychosocial stressors for this population. And so by getting them while they're in the hospital, there may be some opportunities to reduce some of those disparities and access to at least some brief intervention. And then for those who can access or will access, increasing motivation and to access appropriate outpatient care, and helping people get to the types of providers that are going to be able to best help them. We also know that psychologists can play an important and unique role in an interdisciplinary team and really have this extra layer of not just providing the clinical service, but also helping with research and with program development and quality improvement that can really help to achieve better outcomes. And so I think there's a unique place for us there. There's also been research to show that team members do better or feel happier when there's a psychologist on the team. I hear that all the time from my colleagues. Like, I'm so glad that you're here. I'm so glad that I don't have to have that really hard conversation with the patient. There's a little bit of like release of like, okay, I know that these mental health things are happening. I know people are in distress, but I don't know what to do about it. Just having somebody on the team that you know you can rely on and is going to be the person to take care of that takes an emotional burden off of your other team members that I think is really unique. So when we think about what are the core components of a trauma psychology consult service, if we're thinking about this within the context of the guidelines and thinking about what we know about early intervention, we have to screen. We have to be able to triage who's experiencing distress, or at minimum, who's at an elevated risk based on their pre-existing trauma risk factors. From there, we can then narrow in on doing that brief assessment of understanding for that individual who's at increased risk, what do they need? What's distressing them? What do they need help with? And then tailoring our interventions based on those needs and how the person is presenting. This isn't a case of we screen, we know you're at risk, and then everybody gets the same intervention. This is really thinking about, we know you're at risk, we can kind of target some resources, figure out what you need as an individual, and get you on the right path. And then of course, there's going to be those people who are doing okay during hospitalization, aren't really having reactions. There's going to be the people who are more chronic and need longer term support. And so having outpatient resources or outpatient partnerships is another core component. We decided to integrate these components using the Mappit model, which was developed by a group at Medical College of Wisconsin. And so this is exactly what this is something similar to what we do here at UAMS, where our social worker administers something called the Injured Trauma Survivor Screen, which is a yes or no 9-item screener that breaks down pre, peri, and post-trauma risk factors. Based on that, our social worker will administer the PTSD 5 as like a briefer version to kind of look at PTSD symptoms. Of course, we know it's too early to diagnose PTSD, but we're using it as a measure of distress. And then based on those results, I'll get a consult, do a more clinical interview, and then tailor brief interventions there. For some of our people, it's as simple as, hey, you've been through something really stressful. Here are some signs and symptoms to look out for. Here are some things that we know help promote natural recovery. And if you need anything, here's our card. Here's how to get in touch with resources. For other people, it's much more extensive support during hospitalization and really doing more emotional processing and helping with building coping skills during hospitalization, and then connecting with resources once they leave. And then there's the same protocol with depression as well. So in terms of what this looked like at UAMS, back in 2017, when I was here on internship, I did a pre-implementation qualitative study with trauma stakeholders. That led into part of my faculty position and doing that early work and into the implementation planning. COVID happened, and so then we pushed the start date of the actual consult service and to October of 2020. So we've been running for a year now. Currently, we're expanding trauma psychology into the surgical ICU, and then hoping to, by the new year, we'll be starting to expand into the outpatient clinic to get that full trajectory of recovery, make sure that we're getting a continuum of care to make sure that we're really getting the people that we need to get support to. And then hopefully one of the pilots that I'm working on will be developing tech-based screening and routine monitoring to capture those people who are maybe having symptoms even a year out. So I'm going to go through a little bit more detail of each of these phases just to kind of talk more about the kind of experience of implementing the program. So in the pre-implementation study, I did qualitative interviews with different trauma stakeholders, so our APRNs, with our CL service, with our social workers, everybody who might have our physicians, everybody who might have some sort of engagement with this program in some way. And that was based on the CFIR, the Consolidated Framework for Implementation Research, and really focused on like pragmatic development of the program and what we needed to be thinking about to get this done and to keep it sustainable in our system. Many people didn't know that the American College of Surgeons was considering these recommendations, or that this was, something that was being talked about at ACS. And so once they learned about it, they thought that it was a good idea. Most people agreed that it would be helpful. They recognized that there were significant mental health concerns in their patient population, and they saw the advantages of it. But as with most things, there was the barriers of like the system strain. Who's going to do this? With what time? With what resources? And so we knew that that was going to be our biggest barrier. And one of the things that was going to help with that was making sure that we had a really standard approach and a clear protocol of how this was going to roll out, and making sure that this was delegated to a non-physician, which now that I work in the team makes a lot more sense than it did when I first did these interviews. But the idea of developing a new role, which nicely became my faculty position, was kind of supported in this study that I could bring to Ron Robertson to kind of help with building this position. And then people always like to hear how it's going and the real life examples. And so that's been a really crucial part of reinforcement, is being able to come back to the team and say, hey, remember that this patient that you referred, here's how they're doing now. So once we did the pre-implementation study and we kind of had everybody's thoughts and all these ideas about what to do, I got to work with actually thinking about how it could be done, and looked back at the literature, looked at my data of what were the basic requirements for a trauma psychology consult program, and what were those points of choice? Where could we make sure to adapt it to fit into our system based on the resources that we had and the people that we had? And so then I spent some time building the skeleton of an implementation plan worksheet, based on the Query Implementation Planning Toolkit, and Sarah Landis and Joanne Kirshner helped me a lot with this. And I learned a lot from Sarah's work of implementing caring contacts. And we sat down as a team and we went through all of these things and decided, like, when do we want to screen? Who do we want to have do it? What are we going to do once this gets into play? And it was a working document that was very collaborative, and everybody knew what the program was going to look like a year or more before it ever came to fruition, which I think really helped with implementation and really greased the wheels of buy-in. Then we got ready. We're like, okay, now we know what we want to do. Let's get to doing it. So I did a lot of collaborating with Eva Gerbitz, who is my UAMS angel, in building a new EPIC navigator, which is our trauma, alcohol, and PTSD navigator. It has all of the questions of the ITS broken down into pre-trauma risk factors, which is basically asking about pre-existing mental health history, things happening during the trauma. Did you think that you were going to die? Do you think this was done to you intentionally? And then some of those early reactions that we see that are related to depression and acute stress that would put somebody at risk for later PTSD, feeling emotional detachment, crying and are unsure why, feeling more tense, jumpy, increased worrying, kind of that also gets at those life stressors. And then thinking that the world's unsafe and that people are not to be trusted. Our amazing social workers, Katie Keene and Amanda Deal, really did a lot of the legwork in implementing the screening, and Amanda still does all the screening for me and keeps track of all the numbers and everything, and that's been a huge help. And we collaborate very closely on making sure that consults get in and getting information about these screens. I did a lot of training on clinical topics related to the trauma population for care management, and I got the chance to work with AR Connect and teaching them some skills from psychological first aid, and knowing that this is going to be a big referral source for me. I think that I'm the number one referrer to AR Connect. I want that confirmed. I want a badge if that's true, but it's been a lifesaver for me to have the AR Connect team to get these people connected to resources once they leave the hospital. And then providing a lot of nursing in services on the role of trauma psychology and trauma-informed approaches. And so I got to go to the morning 7 a.m. Rounds and the evening 7 p.m. rounds for a little while there, just to make sure that everybody knew who I was, what I was doing there, and that I could be a familiar and friendly face. And then we did it. We've been doing it for the last year, and Amanda's doing all the screens. We don't have perfect numbers. I'm still working on like how to best get the cleanest data to kind of get this information out of EPIC. But to date, we've had about 235 positive screens, and I've completed 260 consults. And the reason why those numbers are off is because, of course, most of our screens are coming from from the positive screens. But I also have really made sure that the team knows that anybody can put in a consult for me. So I often get consults from our speech language pathologists, from our physical therapists, our APRNs, our physicians, for people that may or may not have screened positive, or we haven't had a chance to screen yet. And there's a lot of different consult reasons that come up. A big one is this adjustment to hospitalization or injury, traumatic grief, pain management, mechanism of injury. Some of the systems that have implemented PTSD screening and brief intervention do automatic referrals for things like gunshot wounds. We don't have the capacity to do that here, so we still do it based on screening. But that would be something that would be really nice for us to have in the future. And then making sure that I, have updated referrals and utilize AR Connect and my lovely Walker family colleagues a lot to help me with supporting these patients once they leave the hospital. And of course, our Psychiatry CL team, who have been wonderful partners. And it's been nice to know that they have my back with some of our more acute patients, since I'm not on service every day, and they've been great to collaborate with. So the things that are in the works right now and kind of thinking about extending the reach of trauma psychology is, as I mentioned, my fellow Brittany Haig has been helping me to build more psychology services in the surgical ICU. Dr. Melissa Cost, who's one of our trauma surgeons, has been leading an effort to start to do goals of care conversations earlier with patients and their families, and we've been part of that interdisciplinary collaboration along with the chaplains, the palliative care, social workers, and care managers. I'm also doing these two pilots. So thinking about the TRI pilot to assess the usability and feasibility of something called Blueprint. That's what this picture is here. It's app-based, but also can be received by text. There's an online portal and an email that we can really set up routine monitoring to be sure that we're checking in on patients once they leave the hospital. The goal would be that we can develop the interface so that if somebody's screening positive or based on the symptoms that we're reporting, they'll be brought to a part of our in development web-based tool that would be matching their symptoms and giving them the information and resources that they need, and making sure that our trauma nurse is aware of who's in distress and helping coordinate getting connected with resources. And then the interprofessional small grant that I'm working on, we're implementing brief intervention in the outpatient setting, and it's actually an intervention that's nurse administered, and it's 2 sessions. It's called brief dyadic intervention, and it's been shown to minimize the risk for PTSD 2 years out from injury. So small amount of resources for a potentially big impact. So that's what's hopefully going to be starting in the new year. And then I have to, of course, mention my colleague, Nikita Lovelady, who is working on hospital-based violence intervention program as we speak. She's doing the pre-implementation work right now. And so our trauma psychology service, I hope, will be doing a lot of collaboration with that and helping to provide some of the mental health components of that program. So the key takeaways, this acute care setting offers a unique opportunity to implement prevention and early treatment interventions that can improve both physical and psychological outcomes. And in the field of early intervention for PTSD, when is just as important as what when considering implementation of mental health interventions. And I think that integrating mental health programs into these non-mental health settings is hard, but it's worth it, and we need more. So I would love for this to not be the last specialty consult program that we have. And so I think there's things to learn from what I've developed that can apply to lots of different types of services within our hospital that would really make a difference and promote both physical and mental health for our Kansans. I'll stop there. Thank you so much.
All right, thank you, everyone. Wonderful talk, really appreciate that. We have time for questions. I'll go ahead and lead off the first one. Great presentation. I'm most interested personally in that resilience group from the Bonanno chart in his work. And I'm curious, what data are you collecting in those individuals who screen negative on your survey? Is there any data collected either in EPIC or in the smartphone app you're developing, which might help us better define resiliency and maybe factors contributing to resiliency?
Yeah, I would love to do more of that work. I have not. So basically what we're collecting now is, I think that there's opportunities to look at some of the data in EPIC of like, are there things about more of probably what we could capture would be things of like looking at the mechanism of injury and some of these other risk factors. We haven't done anything around like maybe the personal factors, like either the individual factors of the patient or their support system or things like that would likely be part of what's contributing to that resilience. But I would love to do more of that work, definitely.
Yeah, that'd be wonderful. That's very interesting. Any additional questions? I have more, but I don't want to hog it all up.
I'll throw one in.
Yes, please.
I mean, super impressive, Sasha. It's just like, I know little pieces of what you do, but it's really amazing when you put it all together, how much that you've accomplished on all of that. So super inspiring talk, and want to say that first. I was wondering if you could expand a little bit more on your like collaborative implementation planning process. I think that that's like, I know I have a little bit of a window into how I've done something similar in my work, but you know, it strikes me that this isn't often how we plan things. Kind of getting everybody at the table and really concretely going through that with so many different stakeholders there. So I would love to hear a little bit more about kind of what that looked like in such a multidisciplinary context.
Yeah, thank you. It's really fun and very intimidating because it was kind of this big group of people where, you know, I kind of did some snowball recruiting where like I had a really strong relationship with both of our APRNs. And so I was like, okay, who needs to be involved? Like, tell me, like, give me the people who are going to be suspicious of it. Give me the people who are going to really support it. And like, let's, you know, kind of work together. I think that my tact with that is before we scheduled the meeting, I did something nice for each one of those people. I was like, can I offer you a training in this? Can I help solve this problem for you? And so by the time everybody came in the room, I feel like I had enough of a unique rapport with each individual, even if they weren't seeing eye to eye, to like be able to kind of manage some of those dynamics. I think like having a background in group therapy helps, even though that everybody was very well adjusted. But the thing that I've started doing more recently that I've really liked actually is using something called brain writing, which is this idea of you present the problem and you have people write everything that could potentially go wrong. They describe it as like a pre-mortem. So it's like, tell me every criticism you have for this thing. And then you develop all of that and everybody does it on their own pieces of paper. And then they pass it to the next person and they can expand on their comments. And then you kind of come together, look at it and problem solve around that. And the feedback that I've gotten from the group was really great, is that for people who kind of perceive themselves as lower on the totem pole, it felt like it really helped to redistribute the power dynamics, and that people felt like they could talk more and they could kind of think through more of their ideas. So I've really liked that approach actually recently, and we were able to do it actually virtually using a Google Doc. So everybody was truly anonymous and just typing in at the same time and expanding on each other's thoughts in a really cool way. But I think that to kind of wrap that up, I think that having some ideas of choice, of not starting from ground zero. Like, I think it was really important for me to say like, okay, here's 3 options for screening. Which one makes the most sense for us? Rather than like, what should we do for screening? So kind of pulling it in a little bit more based on our expertise, describing it, and then letting people kind of use their expertise of the context to pick the best thing.
Thank you super much.
So I
Any
have a
additional,
question.
please, Dr. Calvert, please.
So when I was at Children's Medical Center in Dallas, I was also at an integrated care clinic. And one thing I found challenging was consistently having the screeners administered. And there were lots of reasons why: clinic flow and technology not working right. Like, there's all kinds of reasons why it doesn't happen. So I'm wondering, one, how you have problem solved that, and 2, how you think sort of the screening is going after problem solving.
Yeah, that's a really good question, and was one of our biggest concerns. I think that we have gone old school and we do it on paper, which has helped with the tech issues. Also making sure that it was short enough, but one of the big pieces of feedback that I got in the pre-implementation was like, this needs to be attached to existing processes. So our social worker has to go in and see every patient anyway to talk about discharge, to, do their initial assessment. And so having it built in there, I think, is really helpful. Also, though, with our patient population, some people are altered, their mental status, they can't participate, they're in too too much pain, they're in the OR. So we do have a lot of unique barriers in terms of that, but I do think that that initial, I think what helped is that it didn't feel like a top-down initiative. I worked really closely with care management, really closely with our social workers of why this matters, why it's important, how it can help. And I think I just lucked out with having a really great team who's very, very good at doing the screeners and prioritizes it. But I definitely could see how if the pieces were a little bit different, it would be a lot harder. I think that I'm also like not, I'm a little bit flexible in terms of like, if Amanda is really overwhelmed that day, like I'm not above like taking on the screeners myself, and getting those in or putting them into a consult that I already have. So if I'm getting a consult for another reason from another team member, I just take on that screener. I'm like, I'm going into the room anyway. Like I need that information. I'll just get it. So we can kind of be a little bit flexible and adaptable about how the information is rather than getting really rigid about like, it has to be done by this person at this time. And that's just the nature of our environment, is having to be really flexible.
Thank you.
Well, I believe we are out of time. So again, Dr. McBain, thank you so much for interesting work, and everyone join me in thanking our speaker for her time.
Thank you so much, everyone. If you have questions or want slides or anything, please feel free to reach out.